Yeah, I am going to talk about training and education in digital medicine in the next around 45 minutes. And we'll give an overview of certain activities that's been done so far. A few words about myself. I'm the head of the Office for eHealth, surgeon by training. Um, and have also a degree in medical informatics, and have the allowance to train physicians in medical informatics, Weiterbildungsbefugnis. So from our Chamber of Physicians. So let's start. I have nothing to disclose concerning this talk here. So when we talk about telemedicine, you see a post from Johns Hopkins. That was posted last year, so they already had 2 million telemedicine visits. So if you see this, you could say, well, okay, it's telemedicine, it's okay, it's established, it's running, so there's no need to talk further, because everything is great. I guess most of you will not disagree, especially in Germany, that everything is really great in telemedicine. There is a lot still to do, what we need to do. And if we look at, let's say, how far are we concerned with digitalization in healthcare in the EU, in Germany? So we are basically one of the last countries here, only the EU here considered. So there's still a lot to do, and was published also last year, sorry, in 23, 2 years ago, from the Boston Consulting Group. And there's someone still waiting here, so I will let Mr. Danieli enter here. So there's still, let's say, room for improvement, and so sorry, but my office is close to the trauma surgeon surgery here. So if you hear these horns, I will have to wait until.
No, we don't hear any sounds in your voice. Everything is
Okay,
great.
that's great. That's great. Yeah. Okay, so what we are sometimes experiencing currently is when we want to get some things done, then we are more or less concerned with ourselves and more or less fighting against each other, and not so much orientated in finding a common goal, because everybody has different ideas, different thoughts of how things should work, and also some things that need to be considered. So we use tools also in a, well, not the appropriate way sometimes, like this shield here. And of course, you don't get things done this way. So say, how did we get here? How could we end up in this situation? And historically speaking, if you look at the development of the physician, of the image of the physician, so we look way in the ancient times, you see Hippocrates, you see the old Egypt, who also did some surgery on the eyes here. And even further ago in history, these skull here, you see these holes, these trepanation holes here in the skull. You see also that the bone has healed. So the person did survive the surgery here. And we do this trepanation still in modern times, of course, with other techniques. But the idea is the same. So when we look at the image on how I grew up, when I started med school in the late 90s. So in Germany, that was the Schwarzwald Clinic, the family physician, George Clooney emergency room. And you see that medicine is very male dominated, which has changed. And you see it was very focused, and the way that one physician could do everything, like Professor Brickman here, he knew everything, he could do everything, so he didn't need any other physician. And of course, this has changed as well because no single person can have all the medical knowledge. So 2018 here, Ada, the app, where you can ask, I don't know if everybody knows Ada here. I think most of you will. If not, it's free. You can download that on your App Store or Play Store. And you can enter symptoms, and Ada asks you depending on the last symptoms. So here's a YouTube link where you can watch a video where a mother says, well, I'm having headaches, and then Ada asks, okay, when do these headaches appear, and do you have other symptoms, etc., etc. So Ada asks a lot of questions and then comes up not with diagnosis, because it's not meant to diagnose, but it comes up with probability. So it says from your symptoms, 8 out of 10% have the following disease, etc. So try this out if you like. It's pretty good. It's not a artificial intelligence, because there's a decision tree behind this. So you know why Ada comes to which decision. And it's also used professionally. There's a professional version for rare diseases. So which apparently, because they're rare, most physicians do not recognize a rare disease when they face one, which is also rare. So these can also help physicians. Yeah, but you also see it's the new millennium. We do need to collaborate. We need to work together. So one thing that I always show you, even if the pictures are a little older, the principle is the same. So imagine you suffer an accident somewhere in the country, and the ambulance services will bring you to the next hospital. So let's say this is your next hospital. And then they do an X-ray of your pelvis and you see this. So even if you're not a physician, you will see that this looks a little strange, and it's not the way it should be. This is actually a life-threatening situation here. And you need some surgery. You need to have a good surgeon who does the appropriate surgery here on your pelvis fracture. So the greatest wish is that you end up like this. So the pelvis, the pelvic bone is like it should be already. The question is every hospital able to do that? Does every hospital need to be able to do that? If not, would it possibly make sense to get a second opinion? See, I have this complicated pelvic fracture here. Is that something that we can do here, or should we better transfer the patient to a center which has more experience? And apparently, as a patient, if you do have that, you cannot by yourself get a second opinion. So you need the hospitals, the physicians to work together, especially with all the higher degree of specialization in medicine. As I said, there is no single person with all the knowledge. So, but you need special knowledge all the time. So you need to be able to ask somebody who knows this. And if you look on a map here of North Rhine-Westphalia, you see Münster is here in the middle. You see the red spots. These are the level 1 trauma centers. So we have one in Münster, we have one in Bielefeld, we have two actually in Osnabrück, and we have one in Enschede in the Netherlands. But you see that there's a lot of open space around here. So you have an accident like here in Warendorf, and you have a severe accident, you might want to be transferred to Münster or to Bielefeld. So, but you may want to be treated first here in Warendorf and then transfer for a special kind of surgery. So people need to work together. And there is a system being established where you can exchange X-rays, and that's been established 2012, so 13 years ago here in Bochum. And it's now, especially nearly every medical institution in North Rhine-Westphalia is connected to this platform. And this platform enables everybody to exchange X-rays, CAT scans, MRTs, etc., any DICOM material with anybody else in the network. So in May, 750 participants were in the network, and more than 1 million investigations were sent in the last 13 years. So this is something which is standard right now. So at least the hospitals are able to send their images quite fast from hospital A to hospital B or to praxis C. So this is a working cooperation there. So this is where we are now, and looking beyond, where do we go? And I stole this slide from Kendall Ho, who had his talks, I think 2 weeks ago. And this is a slide that's actually come from Taxon. So a picture here. And Taxon in 2017, 8 years ago, in New England Journal of Medicine, he tried to define the different areas of telemedicine. So he divided telemedicine into basically 3 fields. So clinician to clinician, clinician to patient, and patient to mobile technology. Mind that in the last field, there is no physician involved anymore. And then he had different tools and services, so clinician to clinician, so communication by email, video, or both, and where that is used in dermatology, so in radiology, so these heavily on images-dependent specialties, but also in intensive care unit, where you have in Aachen and in Münster special tele-intensive care units, which support other ICUs here in the local area and in the Aachen area, and give advice to their intensive care patients there. So this is the clinician to clinician technology. Then we have the clinician to patient. So if the patient needs some advice, needs some medication, etc. So how does he communicate with the clinician? So of course there are all these electronic tools that we have, like video, phone, email. In Germany, we have special systems for the video patient consultation that can be used or must be used actually. So you are not allowed to use Teams or Zoom or something like that to talk to your patients. And a lot of services which use this, especially in chronic diseases, chronic conditions, medication pain management. That's very, very helpful. And then the last point is the patient to mobile health technology. Most of us, I think, will have smartphones, wearable monitors, smartwatches, etc., who track a lot of your data, also a lot of your health data. So one of the largest cardiology databases is actually run by Apple, because they have all these information from their iWatch, from their Apple Watches. And they, of course, are able to do a lot of stuff with that. So the patient depends on technology. As I said, ADA is one example of that. And that becomes more and more complex. So we can integrate all this into the electronic medical records. You know, in Germany, we are currently facing the introduction of the elektronische Patientenakte, the electronic patient record. So there's a lot of potential in combining all these tools, but also a lot of challenges here, which we have to face. See patient to mobile health technology. Who decides if maybe in the future some artificial intelligence can give medical advice by itself? And who decides if that is possible or not, and which artificial intelligence do we allow to give advice and which we don't. If you kind of link this or compare this to the human medical education. So if you end up med school, so you leave med school, so you're officially a physician, that's great, but you're still not allowed to practice medicine completely on your own. You need to have the broad certification to do this, so that you have to face another 5 or 6 years in education medicine you need to have a special exam before you're allowed to do most of the stuff on your own. So maybe, and there are also some papers written on this where the authors suggest that we should implement something like this for technology systems as well. So that we treat the technology a little like the starting human physician. So that's very interesting. But we also need for this also knowledge. Jackson here identified 5 key traits. So there is an advancement in health records, electronic health records. We have a shortage in health professional workforce. This shortage will lead to the increased usage of mobile health and basically standalone physician independent systems. Because there's also huge pressure in finance and also innovative pressure. And of course, the patients, consumers, they expect more than before. So nobody really wants to sit 5 hours in the waiting room for a 5-minute consultation, which could be easily done by video nowadays. So this may be something, so this is from Star Trek, where we might want to look at the future. And then we say, well, okay, where are the physicians? So there are conference in Amsterdam next week, week after that, where also there's a panel discussion, will the future of medicine be without physicians? This might sound a little ridiculous, but there are a lot of professions which do not exist anymore, which exists a couple of 100 years ago. So let's see how we develop, and if the way we practice medicine will be the same in 20 years, which it will definitely not be. So we create the medicine of tomorrow, one way or the other, but we do that. So even if we do nothing, we will create it by doing nothing. So, but then it will grow in a way which we probably do not want to. So it is also our task to create the future we want. And especially in digital medicine, there are a lot of components to consider. So it's not only medicine, it's also digital information technology, but also a lot of processes. So this is something what also differentiates, in my opinion, digital medicine from medical informatics, because it considers more and other aspects. There's also the law and data protection, research, education, financing, and training. So if we want to have physicians in the future which are not also specialists in medicine, but also have a knowledge of digital medicine, which can use digital tools, or better create digital tools, and we should do something. And so the idea would be to actually link these components. So it's not only medicine physicians, it's also nursing, allied health professionals, law, data protection, IT, device and regulations, economics, ethics, etc. And they all have overlaps, and also they rely on each other and require each other sometimes. So in order to move digital medicine forward, I think, in my opinion, you should establish a joint training program. So not just train the physicians, train the IT, train the law people, train the business people, but at least link the training program. So from knowledge to actually be able to do something, to actually do something. So these are the steps, training, education. So you want to establish a broad knowledge. So you can read anything about digital medicine and medical informatics, etc. Okay, that's great. You can also read a lot about the tools. Then you can also train with these tools. But then the last is that you also apply these tools in real life. So you have to get confidence. So if you've never done a video consultation with a patient, even if you know how to do it, you probably would be able to do it. But if you've never done it, you probably do not have the confidence to do it. You probably also have some thoughts about that, so which might hinder you to do it. You need training, which also trains you actually to do that. So work with the tools you're going to use later. And do not this on your own, but probably also work with the tools together with the people who develop the tools. We just had a session with the UX designer of a hospital health information system provider here, which was really interesting, because they try to understand more and more what the actual users need and want. And this can be only done together. So because you see here this cartoon, which I have from the New Zealand Health Informatics New Zealand HINTS side. So we have software and we have technology, and from the outset, they both had a feeling that the biggest obstacle to any collaboration between their products would be interoperability. So we sometimes have great ideas, two great ideas, which would work perfectly if they could work together, but somehow they cannot work together because from the start they had ideas and they designed it totally different ways. And so unfortunately, they ended up not being able to work together. So this is why right from the start. So we need common goals. If we look back at the Asterix comics I showed you, so these people, Asterix, Obelix, etc., live in the village. They have a common goal. They want to defend their village. But we also need a common ground, so community. And we all work in healthcare. So if you're a physician, if you're a nurse, if you're IT, no matter what, we also work in healthcare. So we also have the same goal. We are a community, but we also need the ability to do that. And we need different but complementary expertise. So we need the physician, we need the IT expert, but they will only be great if they work together. So if they have an own culture, and it is, I think, still a way to go to create this culture in healthcare, even the culture in a single hospital. So we do not have different the administrative group versus the nurses versus the physicians, which is unfortunately sometimes still the case. So we need to build a common culture here, and so what we established is a common training program for medical informatics here. So for those people who start their program here, which is just started, so they will spend a couple of days in each of the different departments here and institutions that have something to do with digital medicine. So it's the medical informatics, it's the IT people, it's the medical technology, it's the data protection, it's the security, it's the statistics and research department. So the idea is not only to create knowledge, but also to create a network where people work together and have ideas together and say, okay, well, I have that idea, and can we find something, a common solution for that? And I think this is in every department, there are great people and people want to work together, and you need to bring these people together. And we also have a student program where we teach students here. In 3 weeks is the next session where these students spend a day in our training hospital, and they do, for instance, they do video consultation with a patient who is an actor, so an actor playing the patient. But so they can get an experience of how a video consultation works, and they have done it before. And so they're more likely to do it, hopefully, when they finish their med school and do it later on, and probably have also more ideas of how we can move on. And there are a lot of great training programs if you want to get more knowledge in artificial intelligence. So here is something from the Charité, the Doctor Med KI. So you will see all those slides. They will be provided for you, and so you can, here it's free, and you can learn different models in different advanced degrees where you can extend your knowledge or even get knowledge in artificial intelligence in medicine. So that's very great. There's also inside eHealth a program which it connects all people from the eHealth field together. So you can apply for these inside eHealth that's funded by the Health Ministry, if I'm correct here, and they want to attract bright minds in especially the MINT fields, yeah, so that they can make a career, make success in the field of eHealth. And there's also Digital Avantgarde Academy, which where you can take lessons in visualizations, and so they also provide great material for training. And this just to mention by a few, there are lots of other people on the market. So it's just a few which came to my first mind, but it's not any advertising or any ranking or any that these are do provide a better quality than other programs. So there are also a lot of other great programs there on the market. But the problem, as you can see, is how do we find such programs? Maybe there are some programs right now you've never heard of. And so there are also a lot of programs. And is there a standard? So if you finish one program, and if you finish the other program, do you know the same? Should there be a standard? Should there be at least some common ground? And the question is, again, what do we want medicine to look like in the future? So, and probably it will be a combination of technology and human. In China, they just founded the first artificial intelligence hospital, so a hospital without physicians. So probably the future medicine, they will still have physicians, but they will also have a lot of technology. And for, let's say, the day-to-day medicine, like the common cold, diarrhea, etc., probably you will not see a physician for these diseases anymore. But for the more complex diseases, when you also need human support, then physicians will probably become very useful. But you see, then this will also change the way physicians will work, and will also have other requirements for physicians then. So you must differentiate yourself from a machine, and it's not that an artificial intelligence cannot be empathic, especially. There are some studies that show that the AI can also be some ways more empathetic than some human physicians. Finally, this is what we in the future actually aim for, so that we want to go forward, to move forward together. And finally, some quote here from the American Telemedicine Association, which says telehealth is health, so there is no differentiation between telehealth and health, so it is health. So we sometimes think of telemedicine as some certain specialty subfield, etc., of medicine, but telehealth is health, and we are transforming health every day by the way we work. And so this is where I work. So basically this is the look from my office here. So currently there are no helicopters there, but this is the old surgery here where I used to work long years, 12 years in surgery. I finished this without being Zoom bombed, which is great. Questions, please.
Yes, Christian, thanks for this great overview, introductory presentation. I withhold my questions. I'm not quite sure, can anyone activate their microphones on their own? Could you give it a try, please?
It works.
Yeah, for you, because you're a host. But for example, for Zuli?
Hello?
Yes, works as well. Excellent. So in case, thanks Zuli, in case anyone has a question, just jump in. Otherwise, while everyone is thinking, I'm just wondering, so you made it clear that there might be some conditions where it's necessary to have technology support in the future. And I'm just thinking about the old, the existing approaches, for example, maybe 10 years ago or something like this. There was Watson applied in Israel in everyday physician approaches, and then it was removed at one time, more or less. At least I'm not hearing anything about anymore about Watson. And I'm just wondering if you would have like a two-class medicine, and that might be over borders due to regulation restrictions or whatever. We see the discussion we had with the AI Professor Hahn expert 2 weeks ago, who said it's really challenging for Germany, and other countries outside the EU have a much easier application of AI tools. So there might be something like a two-class medicine. I'm just wondering, for your opinion, which would be the better, the more desired group? Is it having still a physician, or is it having just the AI tool, or maybe something in between, and which requirements would be fulfilled, would have been fulfilled to become the best approach?
Yeah, good question. I'm a physician myself, so I will probably not say that we don't need physicians anymore. But if you look at X-rays, so I'm a surgeon, so I looked at X-rays a lot, and as a human, you focus on what you want to see. So if you looked at the X-ray I showed you from the pelvic fracture, the surgeon will see the fracture. But there might also be, if the person is unhappy, there might also be a cancer in the spine. And this is what unfortunately happens some of the time, so that you look at the problem you want to see and you do not see the other problem. The AI will look at the whole picture. It will not get tired. So it can mark probably, so it can support the physician. And I think this is where we will go, where we already are. And then is also the thing, if the patient, you're talking about two-class medicine, and it's I think that's a really good point you have, because what healthcare system, what medicine do we want to offer the German patient? So if we do not allow AI here in Germany, then it might be better to move to the Netherlands and have the X-ray looked over there from the Dutch physician plus the Dutch AI, which will probably identify more problems than the German physicians alone without the support of the AI. So
and especially to jump in, it would benefit the Dutch patients, because then the AI would be trained rather on this cohorts, but would not represent that much sensibility for a European or German cohort. as we have seen, for example, for skin cancer detection, right?
Yeah.
So that's a
Yeah,
biasing factor.
Yeah, so this is this is a spiral where you go to. So you are not trained on the German population, so it's not working as well on the German population as it would be on the Dutch population, for instance. And yes, we are facing this this risk, and it is interesting because in Germany people do spend a lot of time thinking about potential risk when it comes to data protection, etc. But I would like that people would spend more or at least the same amount of time thinking about the chances and the missed chances. So if we do not allow something, which might be okay, which might be not, but we ought to risk something there. So these risk by missed chances, so the death by data protection, let's to pronounce that way. This is something that people should be more aware of, I think.
Could you imagine an environment where data protection could be fully solved by anonymization and other similar approaches? Like where you can protect data while making it still fully accessible?
I hope that we will find a way to do that. It's probably difficult when it comes to genomic data. It's a challenge, and there may be a solution for this in the future. Anonymization, especially when you look at X-ray and CT scans, etc. So they do. There are probably no CT scans the same. So it is very specific. So it's very. Even if there's no name written on it, it's probably also possible to identify the patient if you have other X-ray from the same patient. But there may be ways to do it. Just because I don't know, it's not possible.
Yeah. In case, so I totally agree. In case you have a question, but you don't want to unmute your microphone, just feel free to write it in German or whatever language you prefer in the chat, and we will read it out. So what I think was fascinating me, I mean, it's an image you have shown by Taxon from the year 2017, right? And I was feeling like, getting one step back to our discussion, one stage was missing, and like we see the telemedicine to support patient to physician communication and physician to physician communication, and then we see the communication between patient and technology. But the thing I would have assumed was rather like a triangle where all three are interacting with each other. So would you agree that it might be time to update that image?
Yeah, it's a little old, but the patient monitoring, home monitoring, it's also you can even extend that. So it's not only physician, patient technology, but it can also be physician, patient, other physician, and technology. So that's also done. So it's not one physician, or then you can also integrate the nurses, the other test technologies, physiotherapists, occupational therapists, etc. Other professional groups. But I
That
say
would be beneficial, right? To connect all the experts together. How it is already done in some telemedicine fields, right?
Yeah.
In case there are no other questions.
I have one.
Great.
There are more.
I
Yes.
think what is important, and we see in other fields in medical informatics or medicine as well, are there some statistics, let's say, because we're talking about Germany, how much of, similar to what the Canadian colleague presented, right? About the usage of telemedicine and certain applications in Germany. Are there some numbers? Do we see some ramp up over the years, or we just don't have the numbers here? Because I think if I remember right, British Columbia or for certain provinces, they had these numbers, right? Do we also have this here?
There's the Digitalisierungsreport that's published each year in Germany. But I am not aware of an international comparison of numbers of usage of, say, video consultation, etc. It would be interesting to have. So you can look at the OECD statistics on healthcare. So they have a lot of indicators for healthcare. But to my knowledge, they still not have the digitalization there.
Okay, because then we could also see if in which direction it develops, right? Is it ramping up? Is it staying?
Yeah.
Even if maybe some regulations changing or some investments are done, or other laws are coming into effect, or this kind of stuff. Okay. Okay, good. Or not so good that we don't have them. Okay. Any other questions?
Yes, there's one question in the chat.
Yes.
Which is asking like exchange of radiology images via DICOM you mentioned, and on the map there is in the southern area, mainly marked Heidelberg and Munich. How comes that the others are not involved?
No, they are involved. They have their own network. So this is also interesting. There is a huge network in the southern part of Germany, which is run by Nexus. There's also something. So we have in the northwestern part, we have these Connect MT. So that's the DriveX platform behind that. And in the southern part, we have the Nexus platform. So it's not, there's no network in the southern part of Germany. There is a similar network where they are also connected. But there's kind of a little border between the northwestern and the southern part, because all these networks, they originated. So the one here in northwest, they originated in Bochum, where 10 hospitals in Bochum linked together. And then it grew to the northwestern part, and we rarely exchange data from Münster to Munich. So that's very, very, very the case. So it's still very regional. This is why these networks, they work mostly regional. So there is a, thanks, I will change that in the slides. So that's, I did not want to create the impression that there is no such thing in the setup.
But maybe adding to that a follow-up question. Sorry, Zuli, just jump in. So you have DICOM, like an interoperable standard for exchange of images, and then you still have like vendor-based networks. Does that imply that there is still no interoperability available between these vendor applications, or is it challenging?
The interoperability would be there. The thing is the verification of the addresses. So you send that from hospital A to hospital B, and you so this is the thing. So that you want to make sure that your DICOM data arrive in the hospital you want it to, and this is basically what these networks are responsible for.
Still a challenge. Thanks.
Yeah.
Sorry, Zuli, or thanks, Zuli.
And just maybe it's a stupid question, I don't know. But the thing is this data from these nets first comment and MT or the other institute, this data is available for research too, or it's just only for the patients and the communication between clinicians?
I did not understand the
of the data, of this image data, or all this data from these networks is available for research too, or it is only for the clinicians to treat the patient?
Yeah, so currently it is not available for research. So it's just um, an exchange of DICOM data for medical means not for research so far. It could be used for research purposes as well. If you want to exchange research, and it's done to exchange research data, but you cannot access all the data they exchange. Basically, they do not store it. They use DICOM email to send it from point A to point B. It's not stored in the middle. So there would not be a database where you could access all the DICOM data.
But it might be really that when you go via the FTPG,
Yeah.
that I'm not fully sure how well integrated radiology images are already in the core data set, but it might be that they are already there to a degree. So you could go that way maybe to access them from each clinic.
Okay, so like a medic or something like that, as the centers that collect information.
Yes.
Okay.
Yeah. And maybe if I could add on, because we discussed that's perfectly fitting, I assume. We discussed if the OECD has something regarding digital health, and that's even item 2, digital health at a glance. And over here we see the ability to access and link data sets in healthcare. That's totally Zuli's topic. And what we see is like you should ask in Denmark, but not in Germany. Worst can only be United States and Ireland. So yeah, that just briefly to add in.
Yeah, thank you very much.
Thanks, Sebastian. Okay, any other questions? So then we would be finished a little earlier.